Good evening, Patrick Henry. This is Mr. Ray. This is one of two small, brief lessons that I'm going to post. Both of these can be found and will be needed to complete a couple note sheets that are listed in the document resource section of Synergy. If you notice in the background, this is a resource that will be listed under the notes. Make sure that you grab this and fill this out as we go through it, and then of course submit it back to me through the Dropbox option that is in Synergy. But the PowerPoint itself, we should be able to go through this pretty quickly. This lesson is just an overview on mental disorders. This is Unit 12. Many of the disorders that you will look up for homework and that will kind of be hinted at a bit as we go through this overview. Many of you already have a decent working understanding and knowledge of some of this. A lot of this is owed to greater awareness in our society now. Some of you may actually have experienced or have one of the conditions that we are going to talk about or that you'll look up for homework. And then also the media. Media often plays a role in our awareness of some of these things. But the point of this is just an overview. Clinicians look for 3 classic symptoms when labeling a mental disorder. And as I go through this, hopefully you have also pulled up the note sheet to fill out as we go through. And make sure that you submit it to me so I can give you credit through the Dropbox option in Synergy. But the 3 classic symptoms that a clinician is looking for. A hallucination will be the first. Hallucination of any sort, could be auditory, could be physical, but a false sensory experience. A delusion, a persistent false belief. And an affective disturbance, an emotional disorder. Now, some of you may be looking at these 3 and thinking, well, my goodness, this applies to me all the time. And while that may be, it is also worth noting that there is a difference. One who might suffer from an hallucination, they are unable to discern fact from fiction, whereas your rational mind, can come to the conclusion that maybe what you're experiencing, what you're hearing, is all just a figment of your imagination. Similarly, you may be in denial of something, but still, eventually in time, your rational mind will weigh out. As opposed to somebody who is consistently delusional, their rational mind is not having those kind of conversations with them. Also, from an overview standpoint, there are 2 views of assessing mental disorders, the medical model and the psychological model. From the medical model, disorders are seen as a disease. And consider for just a moment what that entails. If the mental condition is a disease, then you are not at fault. It is faulty brain chemistry. It is in your genetics. There's a family dynamic and history that may have brought along that mental malady. Also from the medical model, the DSM, the Diagnostic Statistical Manual, now in its 5th version, that's what the letters DSM stand for, is the Bible for identifying and diagnosing disorders. It is also worth noting that your textbook goes by the DSM-4, so most of the labels and classifications are slightly out of date in your textbook. But the DSM-5 is currently what is in use, and again looks at and views all of these mental conditions from a medical standpoint, and it can be addressed as such. The psychological model, on the other hand, views disorders as a mixture of social, cognitive, and behavioral features. And many of these are perspectives that we have looked at off and on throughout the year. Social would imply the environment. Cognitive would imply one's thoughts and perceptions. And behavioral would also imply rewards and punishments and consequences. Consider for just a moment 2 types of conditions, both of which will be looked at and looked up on a later homework assignment. But consider for just a moment schizophrenia. From the psychological model, this one may not apply. but the medical model definitely would speak very heavily about the criteria to warrant a schizophrenic diagnosis. That there is probably a family history, there's faulty brain chemistry, but at the same time, the psychological model would be very good in addressing a situation like PTSD that would fall under the trauma and stressor related arm of the DSM. A combination of these three features would probably give somebody or have somebody at a greater risk for PTSD, post-traumatic stress disorder. Consider for a moment the person, the environment that they live in. Consider for a moment the thoughts and perceptions that would go with that faulty, harsh, traumatic environment that they have experienced, and the different rewards and punishments that would be connected with that. Continuing, behavioral aspects of disorder. Positive and negative symptoms. Now, positive and negative do not mean good or bad. Positive means that it is noticeable. It's treatable. So, consider for just a moment OCD, the noticeable, treatable symptoms that would be connected with OCD, obsessive compulsive disorder. The obsession, the thoughts may not be a positive symptom, but the compulsion would, the actions. So maybe somebody who has to wash their hands so many times a day, or has to flip on the light switch so many times before they enter a room. Those would be positive symptoms. They would be noticeable. They could easily be documented. As opposed to negative symptoms. These would often maybe go unnoticed or could perhaps be written off as something else. So, for example, somebody who is suffering from depression, clinical depression. Clearly, there would be positive behavioral symptoms that would be noticeable with that. Maybe a decline in somebody's grades, maybe a reluctance to hang out with people, maybe they're distancing themselves from their friends. Those would all be positive symptoms, but the negative symptoms that might be written off as something else. Maybe they're sleeping a whole lot. Well, that could be written off as something completely different that has nothing to do with depression. Maybe a listlessness that they might have could be written off as something else. Where does the disorder originate? And these nature and nurture are themes that we've looked at off and on throughout the year. From a nature standpoint, DNA, family history, genetics, any buzzword that will go along with that. And the disorder homework assignment that you will have to fill out, do consider that there is strong, compelling evidence for most of the ones that are on there that it is genetic in nature. But that is not to disregard the nurture side of things. Nurture, from what we've talked about off and on throughout the year, would imply upbringing and life experiences. All the things that have nothing to do with DNA. Consider for just a moment clinical depression. Best evidence would suggest that it is nature in origin, DNA, genetics, family history. But then also consider for a moment one's upbringing and life experiences could make that far, far worse than somebody who maybe grew up in a better environment, better life experiences, better life circumstances. Also consider for just a moment, and this is kind of what the diathesis stress model suggests. This is oftentimes connected with schizophrenia, but one can make the argument for almost all the conditions and disorders that you will look up for homework, that there is a nature and nurture driven aspect to it. Consider for just a moment PTSD. Now, on the surface, PTSD, post-traumatic stress disorder, would seem to be more nurture, life experiences, traumatic experiences at home, surviving a war zone would all probably prompt somebody to develop the symptoms of PTSD. But maybe the person has a genetic leaning towards these things. Not everybody that experiences things of that nature ends up having PTSD. So the diathesis stress model looks at both nature and nurture in explaining different conditions. And students, when you are finished filling this thing out, typing this thing up, do not forget to send it back to me through the Dropbox app. Have a good day.